It's now time to introduce our next guest. It's Professor Nicholas Carleton. Nicholas Carleton, PhD, is a professor of clinical psychology, a registered clinical psychologist in Saskatchewan, and the scientific director for the Canadian Institute for Public Safety Research and Treatment. He is principal investigator on the Royal Canadian Mounted Police Longitudinal PTSD study. Now, Nick is joining us today via Zoom. And welcome from Adelaide.
All right, thank you. This morning, I'm going to provide a little bit of background on some of the work that we've been doing at a national and a federal level that we're quite excited to share. And then I'm also going to provide some of the background on some of the larger scale studies, the details on some of the larger scale studies that we've run over the last 2 years as a large scale team across the country. So let's start into that. I don't have any disclosures. I'm a professor of psychology. I'm a registered clinical psychologist. I see and treat patients still in the province of Saskatchewan, which is in the very center of the country. I'm serving right now as the scientific director for our Canadian Institute for Public Safety Research and Treatment, which I'm going to call CIPSRT for short, because otherwise we won't have enough time for the entire presentation. I am very privileged to have a tremendous amount of research support coming from the Institute itself, from the Canadian Institutes for Health Research, Public Safety Canada, and several other of our federal and provincial agencies. So let's do a brief history tour. We could go all the way back to around 760 BC, which is the very first evidence that we have of discussions about things like post-traumatic stress disorder, and that those discussions came functionally out of conversations with military members that ended up being recorded in poems and songs and ballads. But I want to jump ahead because we only have around 20 or so minutes. So I want to jump all the way ahead to DSM-3, 1980. This was the very first time that we had post-traumatic stress disorder as a formal diagnosis. Now, we had some diagnoses before then, but this was the result of stunning advocacy, and it came about as a function of things like post-Vietnam War syndrome, and was really brought about by friends and family members and veterans pushing, demanding that there be a diagnostic recognition and then support for mental health thereafter. We had a revision to that in 1987, wherein they began to narrow the field as to what was eligible to be diagnosed. And so it had to be an event that was outside the range of usual human experience. And that event had to produce difficulties with re-experiencing, avoidance, numbing, and hyperarousal. So I raise this as an important starting issue because what's outside of the range of normal human experience is hugely subjective. And my human experience is very different, for example, than the human experience of many of my colleagues and many of our police officers who work, for example, in Calgary Police Service. So that's an important contextual cue that I think we need to be mindful of. We then started to see a host of different treatments that have come about and that over the years have developed varying levels of evidence and ongoing support. So pharmacotherapy, stress inoculation, eye movement desensitization and reprocessing, cognitive processing therapy. And all of this is coming about by around 1993 that these different disorder solutions are being offered for things like post-traumatic stress disorder. We saw a host of different research advancements from 94 to 2000. And we see that changes were made in DSM-4 and then DSM-4-TR, where we started to see, well, maybe it's not outside the realm of normal human experience. Maybe we end up with difficulties if people are exposed to actual or threatened death or serious injury involving fear, helplessness, or horror. We see a new range of treatments that are made available, including a prolonged exposure and present-centered therapy. By the time we're at 2001, we're now starting to see a real zeitgeist forming around the idea that we might need to manage trauma and trauma-related incidents in a very different way. By DSM-5, we start to see several changes. It's still exposure to actual or threatened death, but we also now include, and this is very important for our public safety personnel and I think for our military personnel, the notion that repeated or extreme exposures to traumatic events in the course of professional duties might in fact be, as a result of cumulative exposure, enough to warrant a diagnosis of post-traumatic stress disorder. This is really where we see some of the recognition that it's not necessarily a single major event. So in Canada, we've had things in the last year to 3 years, like the Humboldt bus crash and the incident that we had in Moncton. Those are major events, and they can certainly impact people's mental health. But also it can be the hundreds of what might otherwise be considered commonplace events that our public safety personnel are exposed to as a function of their vocations. that might warrant a diagnosis so that they can access treatment and get support thereafter. In November of 2015, our Prime Minister produced a mandate letter to our Minister of Public Safety, who at the time was Minister Goodale, and said, we want you to work with the provinces and territories and the Minister of Public Health to develop a coordinated national action plan to address things like post-traumatic stress disorder, which are disproportionately impacting our public safety officers across the country. This was a galvanizing moment because it was an opportunity for Canadians to come together and try and address what we that have worked with public safety personnel have believed was a serious problem, and we can now address it at a national level. As a function of this, we were privileged. The first national roundtable that we had on PTSD happened in my home city here in Regina, Saskatchewan. And one of the requests that was made at the time was, Nick, make sure when you're doing your introductory presentation that you can tell us about how many of our police officers have difficulty with post-traumatic stress at any given time. And so like any good professor, I sent my graduate students to go and scour the literature. And as they were scouring the literature, they came back, and the best that they could find was a few studies, many of them international, very few in Canada, and they produced a range of estimates somewhere between 1% and 37% of our police officers might be having difficulty with PTSD. So that's difficult for me because that suggests I need to go back to the federal government and say, well, for our public safety personnel, which are around 325,000 people, I'm going to need additional supports for between 1% and 37% of them. And that's simply not an accurate enough figure. So we began working quite rapidly then to try and close that gap. By October of 2016, there was a report that came out that emphasized the diversity of public safety personnel across the country, saying it's not just our firefighters, our police, and our paramedics, although they're certainly important. It's also our border services agents, our communications officials, so 911 operators and the call center operators. It's the support teams that work alongside our public safety personnel. It's our correctional workers and employees. It's a host of community agents that are off working to protect our public safety 24 hours a day, 7 days a week. By 2016, January, there was also a bill that was introduced saying that we had to do something about these challenges. And I want to note that at this point in time, it was only February of 2017 that we actually had clinical practice guidelines delivered for the first time by APA, specifically for adult PTSD treatment. So we're not even 40 years out from the first PTSD diagnosis, and we're already making really rapid improvements and rapid gains. By August of 2017, we began to be able to provide better estimates for our public safety personnel with respect to the difficulties they had with PTSD. But as a result of the research that we'll discuss shortly, we also were able to say it's not just PTSD. We're focusing heavily on that. And as a PTSD researcher, I suppose I'm okay with that to some degree, but we're seeing a host of different challenges facing our public safety personnel across the country. And we're hearing similar challenges from our colleagues around the world. By 2018, in the summer, we had a federal framework on PTSD Act that was made available, where the federal government and several national and provincial agencies came together to build a framework for how we were going to address the challenges that were originally mandated to be solutioned as part of the 2015 mandate from our Prime Minister. By 2018, the Planning Committee had begun work, and by April of 2019, we finally had a national action plan on post-traumatic stress injuries. We had changed the language here from focusing only on post-traumatic stress disorder or mental disorders so that we could in fact have a broader discussion. And that was a discussion that included many different kinds of disorders, but also recognized that for our public safety personnel and our military and other groups that work regularly with potentially traumatic events, we didn't necessarily think it was appropriate to suggest that it was a disorder without contextualizing the notion that this was something that may have resulted from something that had occurred to them. So it seemed very much like an injury. And that followed community changes that were made inside our military to focus on operational stress injuries instead of operational stress disorders. By April of 2019, we had the very first national conference on PTSD that was coordinated by our federal government. And we built a common glossary to try and develop singular terms, or at least some basic definitions that the community could use and that our public safety leaders could use and our government could use that still fit with what we understood as academics for close to best practice. And that's, of course, a challenging thing because getting a series of academics to agree on a single definition of a construct can be a very challenging thing to do because constructs are always in flux. So I thought we'd spend a couple of minutes and talk a little bit about our current state and what do we know right now. Well, right now, we're very pleased that we do have CIPCERT, that's our Canadian Institute, serving as a national knowledge exchange hub to coordinate researchers, public safety personnel, and government agencies across the entire country. And that coordination is designed to try and reduce the time from workbench and the research all the way to propagating different solutions for our public safety personnel. And so with that, we're able to, we believe, more rapidly transmit not only the knowledge that we are producing inside of our universities across the country and the collective knowledge that we can glean from our colleagues around the world, back down to our frontline personnel and their leadership. But we also then have a channel by which our public safety leaders from across the country are able to communicate back with us, highlighting their priorities, highlighting their requests for clarification. And we see that actually starting to work better and better with each passing month. So, for example, we're now better able to address difficulties they're having with pseudoscience. So is it that ostrich therapy is a therapy that can actually be used to help our people with mental health if it's costing $200 to $1,000 a day? The answer is we don't have research evidence to support ostrich therapy yet. Perhaps there will be some in the future. And I wish I was joking, but that really is one of the questions that we get asked. So we've been able to create a dynamic, interactive solution that allows us to provide evidence-based information to the front line in a coordinated fashion. All of this is ultimately to help to protect our public safety personnel that are currently serving, our former public safety personnel, their leaders, their families, and to help improve everyone's mental health and well-being therein. So our public safety personnel at this point are now declared to include, but are not necessarily limited to, our border service agents, our public safety communications officials, correctional workers, firefighters, and that's both our career and our volunteer. In Canada, at least, the vast majority of the firefighting across our country is done by volunteer firefighters who are also working other jobs and may not be covered for the injuries that they may experience as a function of being a volunteer firefighter. We also have Indigenous emergency managers, operational intelligence personnel, paramedics, municipal, provincial, and federal police, as well as our search and rescue personnel. There are several unique challenges that they face, and I like to underscore that I'm not suggesting that they are having more or less difficulties or that it's better or worse or harder for one group than another, but it is different. So our public safety personnel service happens different relative to our military. Our military get deployed to what for them is a very unsafe zone. And so they leave a safe zone here in Canada, they're deployed to a very unsafe zone, and then they're brought back home to a safe zone. That's very different than our public safety personnel who are deployed to what for many of them is an unsafe zone. And they're deployed there for 25 years. That unsafe zone is also the zone where they live and work and communicate with each other. We're also asking them to do very different things than one another. Some are responsible for protection, enforcement, rehabilitation, but also very different relative to history. We're now asking them to fulfill multiple roles. They're our frontline for providing mental health support to our community agents. In many cases, they're acting in support roles for our military where they're deployed. This is increasing the complexity of our challenges facing our public safety personnel. So to address that, we're very pleased that we have a host of different academics that are taking on leadership roles and have taken on long-term leadership roles, many of them, to support what CIPCERT's doing. One of them is Dr. Heidi Cram, who's there with you in Adelaide. And Dr. Cram, I'm jealous. I wish I was there with you. But we have people from coast to coast who are working with us right now, focusing on different areas of public safety and our public safety vision. We're also supported by a public safety steering committee, which are the leaders from across our country from the major agencies that represent all of our public safety personnel. And they, in this way, are able to provide a voice, and we are able to provide them with information back and forth. We're supported by a tremendous number of stakeholders, and that includes our Government of Canada, but also our own Public Safety Canada, our Canadian Institutes for Health Research, and our sister institute, the Canadian Institute for Military and Veteran Health Research. We're also supported by numerous NGOs across the country. So a lot of this support gave way to either the development of, the deployment of, or now the knowledge translation associated with what we refer to initially as the Prevalent Study. So I thought we'd focus on this one large-scale study, given the time that we have. The study was launched in 2016 in order to try and narrow some of the information gaps that we were identified as part of that very first national roundtable that was hosted in early 2016. This had tremendous recruitment support from our ministry, from our government, from CIPCERT stakeholders across the country, and we collected data online using a well-validated set of survey measures that were available in both of our national languages, English and French, and that engaged approximately 9,000 participants. So for us, this was our largest coast-to-coast singular engagement study. And the publications and the detailed results are all at this point open access, and the results are freely available on the website. The demographic and geographic distributions from this study were generally representative when we compared them to data from Statistics Canada, our national and federal agency for doing our statistics assessments. So it was reasonably representative of our public safety personnel. That said, it's important to make sure that we're clear that we're looking at a sample here. We're certainly not looking at a comprehensive population sample, a comprehensive population when we're talking about these results. And I'm excited at the idea that we may be able to launch a full-scale stratified random sampling interview-based study fairly shortly. So what did we find? Well, we found first and foremost that in our general population from Statistics Canada, when we do the ongoing assessments using interview-based data, which of course is the gold standard, for things like post-traumatic stress disorder, between 1 and around 3.5%, depending on how you cut up the data, of our general population meets criteria at any given time for PTSD. When we look at our public safety personnel, we see significantly higher rates. Now, these are very stringent, conservative tools that we use, but they were still self-report, so please take that with a grain of salt. We see for our total sample, it was around 23%. For our municipal and our provincial police, it was around 20%. For our federal police, our Royal Canadian Mounted Police, that's around 30%. We saw our correctional workers having difficulties around 29%. Our firefighters were doing a little bit better at around 13 or 14%. That said, it's important to keep in mind that that's still orders of magnitude higher than our general population. We saw difficulties being experienced around 18% for our communications officers. So those are our 911 operators, our communications network center operators. There's a host of communications officials that provide support. We saw a similar pattern for things like major depressive disorder, generalized anxiety disorder, social anxiety disorder, panic disorder. Our alcohol use disorder rates were the only ones where our Public Safety Steering Committee raised a question, and the question that they raised was, are you sure? Because we think that while we accept a lot of the other numbers are probably correct, we think many of our public safety personnel might have been hesitant to give you honest answers with respect to alcohol use, because there would have still been some concerns that there might be some way by which they could be identified. So in our general population, at any given time, approximately 10% meet criteria for one or more mental health disorders. Based on the screening data that we have for our public safety personnel, the number is closer to 1 in 2. So that's of grave concern for us. And if you're interested in learning more or investigating some of the additional details, please do make use of the publication that we have. It is open access. There's several limitations, and we're building to address those limitations in up-and-coming studies. At the same time, we also assessed for things like chronic pain. And in our general population, we see difficulties with chronic pain at around 19% for any chronic pain. And the vast majority of that is lower back pain. When we looked at our sample, we actually, of public safety personnel, we were able to identify that about the same number are having difficulty with lower back pain, which surprised us. There's some variations. Certainly our paramedics and our RCMP and our correctional workers seem to be having more difficulty. But when we take a look at all of the other different areas for chronic pain, we're seeing much, much higher rates there. And we were asked why. And one of the first questions we were asked as part about why is it that the public safety personnel are inherently more reckless? Perhaps they're taking bigger risks in their recreational time. And we'll get that and address that question in just a moment. But one of the things that we responded back was, well, we think that if they were being more reckless, you'd first of all see that it was across the board that they were higher. So they'd have more difficulties in lower back pain as well as everything else. Instead, what we're seeing is difficulties with shoulder pain, neck pain, arm pain, leg pain. If you think about the things we're asking them to do, if a firefighter or a paramedic or a police officer is busy trying to pull me out of a car wreck, they're probably not stopping to wait and make sure that they've got the appropriate weight belts on. They're not stopping to look after their own personal safety, because that's what many of them don't do. They're busy looking after my personal safety. So they might be reaching out, they might be extending at odd angles in order to try and protect the rest of us. And that seems to make more sense than the idea that they are perhaps engaging in more reckless behavior. In fact, when we asked them about that, 40% of them were able to identify a specific single active duty incident wherein they remember being injured and having that injury being directly related to their current chronic pain difficulties. We saw that certainly very clearly for our RCMP and our paramedics, but you can see that for a large portion of the chronic pain. These people were able to specifically identify an event, and that event was an on-duty event. So we see that certainly they have some other difficulties that they're having across the board, but we felt that this sort of addressed some of the arguments that were being made with respect to there being this sort of reckless personality that would be engaged in these behaviors. We also assessed suicide, and we saw difficulties with suicidal ideation and planning, and attempts, past year and lifetime. And we saw that those rates were double or more than our general population. So in the past year, you can see that for our public safety personnel, our paramedics, for example, get highest at almost 1 in 100, reporting at least one suicide attempt in the past calendar year. When we look at lifetime rates, we're seeing 1 in 10 for our paramedics in the last during the lifetime that tried to die by suicide. The statistics here are particularly sobering, I think, and I'd like to highlight for everybody why they're particularly sobering. It's that our public safety personnel, if they choose to die by suicide, unlike the general population, if our public safety personnel choose to die by suicide, they are going to be far more capable of dying by suicide, certainly than myself. So if a police officer decides that she or he is going to die by suicide, they're able to do that very readily because we're often arming them. They have that capacity. But so does a paramedic. Many firefighters, correctional workers, these people know how to die by suicide quite rapidly. So we think that they might be underreported. We were also asked to check out, well, what are the events that are associated with dying by suicide, with difficulties with post-traumatic stress disorder, because they wanted to identify a specific subset of events, and we didn't see such a subset pattern. Instead, what we saw was tremendous amounts of exposure to a host of different kinds of events. And then if you look at the far right hand, and many 11 times or more, and if you look at our far right-hand column, you'll see that all of them were associated with difficulties with post-traumatic stress disorder. And so we didn't see a single subset of events where we should be allocating resources. In fact, it looks like what someone experiences might be unique, and they might need to be able to access those resources at their own beck and call. We did qualitative analysis on several of these, and as a function of that, we were able to identify a variety of different challenges. They're alienated from their past selves. They perceive themselves as powerless, forsaken by their employers and government. And the number one thing they asked for was recognition from the community that they were facing challenges. And the number two thing that they asked for was demonstrable support from their public safety leadership and from the government. Well, one of the things that we did an analysis on, and additionally cross-sectionally, was, is there a specific kind of training that is associated with a lower probability of screening positive for one or more mental health disorders? The answer we found was any kind of training appears to be associated with a slightly lower risk, but there doesn't appear to be one kind of training that is better than any of the others. We also took a look at what they would prefer to see with respect to help. And what we found is, most of the time, the number one resource they want to access is their spouse, their friends, possibly their colleagues. They're willing to talk to their family physicians. They're not as willing to talk to their psychologists or their psychiatrists, and they're not as willing to use their employee assistance programs. So what this tells us is that part of the frontline we should all be addressing is a frontline focused very specifically on family members and spouses, because that's their first resource. So let's make sure that we're supporting them. I want to just cover very briefly some of the next steps that we're taking here in Canada. We're working towards producing a host of different researchers that are coordinated. We awarded 21 Catalyst grants in order to galvanize research across the country, and we're about to award 8 more long-term grants, all focused on public safety research and public safety researchers, and bringing them together to solve public safety problems. We're continuing work on the Longitudinal RCMP study, which warrants more time than we have, but it's a large-scale study trying to prospectively identify the variables associated with difficulties with post-traumatic stress disorder and other post-traumatic stress injuries among our public safety personnel, as well as investigating a large-scale intervention to see if we can prevent those injuries using established cognitive behavioral therapy, solutions, and skills. We're initiating a large-scale endeavor to try and promote and provide internet cognitive behavioral therapy across the entire country, specifically to our public safety personnel. And we're building that on solutions from Australian researchers like Nick Titov and Canadian researchers like Heather Hadashravopoulos, who have been working with Nick Titov for some time now. So we're very excited about those next steps together. And we're also working on new leadership training because we believe that if we're going to ask our public safety leaders to provide better, more psychologically safe environments to support the mental health of their public safety personnel, we had best make absolutely sure that we're providing the training to support those leaders as well. So we're tailoring some of those right now. And in fact, we're working with Calgary Police, along with several other police agencies and several public safety agencies across the country, to pilot test those in the coming years. So in summary, as I think I'm getting pretty close to time, if I'm not over time yet, there's a host of different opportunities for us to protect our public safety personnel, and they certainly need it. We need individual, family, organization, and system interventions if we're going to do a better job of trying to prevent and, in fact, manage the post-traumatic stress injuries that we're seeing. There's a lot of demands on their time, but the big demand that we're hearing from our leaders is they want independent, published, peer-reviewed evidence so that they know how to best protect their people and so that they have an evidence base with which to inform their ongoing decisions. We're also trying to manage expectations. So there's a huge amount of demand for us to do something, but we want to make sure we're doing things that are evidence-based as we go forward, and that if we're developing new programs and new solutions, they should be based on good theory. There's a huge need to involve more experienced registered professionals across our country anyway in providing mental health support for all our public safety personnel. And we need to do a much better job of tracking and continuous improvement so that we can make sure that the solutions we are rolling out are having the outcomes that we're hoping for all of our public safety personnel. So with that, I want to thank you all very much again for your time and your attention. I hope this was beneficial, and I truly wish that I was there with you in Australia as opposed to heading home through a blizzard later this evening. So I hope you enjoy the rest of the day and that you have a fantastic conference. Thank you very much again.